Welcome to the Libido Lounge, where we focus on all things love, lust, and libido. We believe that fabulous sex is important to health as exercise and good food. Everybody, welcome back to another episode on the Libido Lounge. I'm your host, the libido expert, Dr. Diane, and I'm so excited about the conversation that we're going to have today. This is board certified plastic surgeon, Dr. Rob Whitfield. And this conversation we're about to have is amazing because I've seen this so many times in my practice where people are sick for a long time, their libido's failing, their relationships are in struggle, they are fatigued, they feel foggy, they don't know what's wrong. And one of the key components to their health is breast implant illness. And that's one of the reasons I wanted to get Dr. Rob here today to talk to you all because personally, I don't feel like a lot of people are talking about this. Like how much, like let's start there, Rob. Like how many people are actually talking about this? Like, do people even know what breast implant illness is? Are people aware of this? Where should we start?
Well, thank you for having me on. I really appreciate sharing this with your audience. I feel like, for 7 years we've been on this kind of journey to help patients, and I just came from seeing one who had been told they were a hypochondriac and they have nothing really wrong with them. So for everybody listening, I consider breast implant illness to be a chronic inflammatory process, and we all face inflammation. In this setting, somebody's developed chronic inflammatory symptoms and they have a breast implant. So are all of the symptoms from the device? Not in my experience, no. So about 30% of the time, the device will have a bacterial contaminant. And we published, or I'm sorry, submitted for publication a large series of over 700 cases of this. And about 30% will have a bacterial contaminant. It can be, in our instance, Cutibacterium acnes. In other studies, it's been Staph epidermidis. So that interaction can lead to more symptomology like fatigue. They're starting to show in studies that. So if you can have fatigue, it's not a stretch to think there's a lot of hormonal disruption. You couple that to environmental exposures or mycotoxin exposures, phthalates from plasticizers, from water bottles. Y'all should not drink out of plastic. Enough said. Um,
Mhm.
that's enough to affect any woman's endocrine system. And if that gets affected, your thyroid typically goes off first. But in my clinic, we look at everybody's sex hormones in addition to thyroid functions because we want to know at a baseline where things are so I can have a better way of presenting how to optimize someone for surgical recovery. And we do that through a preparatory process we call SHARP. And that just really helps us set a playing field. And we want to level it for each patient so that they're not taking months or years to recover from one, what should be a straightforward, procedure. But we do see a lot of testosterone suppression.
So walk us through because I know a lot of the women in my audience are in the perimenopause, menopause range, sometimes earlier, but a lot of times there's already these hormonal abnormalities. So would you like suggest that anybody that's had breast implants should consider this? Like what are people looking out for to really think like, oh, there's something going on here? Is it that your thyroid test is abnormal, like you said? What really should be kind of be that trigger to go see somebody like you?
Well, I'll answer this way. If it was a male having the same type of symptoms where decreased libido, energy levels, focus, they would look at their testosterone level. But
Right.
for whatever reason, in a woman, we don't do that. And women need about 1/12, I would say, the amount of testosterone a male needs in terms of replenishment. And I mean, it's pretty obvious. I just ask the questions like, do you have a libido? I mean, can you work out? Do you have stamina? Do you feel like you have enough energy? I just had a woman in here. She doesn't feel like she has enough energy to go interact with her 7-year-old. That's a incredibly disturbing thing if someone in their 30s to not have enough energy to go interact with their child. So, of course, we're going to look at that and we look at a total and we look at a free level of testosterone. And I recommend, a supplementation. I typically will do a pellet, not a shot, but we do that strategically. So for the audience, I'm not proposing one therapy over another. I'm telling you how I do it in the context of recovery around a surgical procedure. So I want a good 120 days of the right level. And so my patients come in with a lot of inflammation, and I'm going to make more by doing surgery. So I'm really going to spike it. And men have a little protection because of testosterone to buffer out cortisol and estrogen. Obviously, women don't have that because they have, like we discussed, 1/12 the amount, really, if not even less in my patient population. So I'm trying to be more protective around that time to help them recover more quickly, more efficiently.
That makes sense. And then testing wise, like, how are you determining what's like, what kind of tests are really out there for this component of things?
Yeah, we look at it. These are still serum tests for us.
Okay.
Because I'm dosing off of a particular algorithm for them based on those serum tests. So that's a blood
Hmm.
test. I like that based on what we're looking at in terms of dosage when we do a pellet therapy. I do have a lot of people dosing in and around Texas using a injection. I have some people doing compounded testosterone, and then we have people doing troches as well.
And then as far as testing for breast implant illness, is there any other tests that you're doing there?
So we have stuck with a core group of tests right now: saliva for DNA testing to look for both estrogen metabolism and then detox pathways, vitamin D metabolism, methylation, glutathione metabolism, and antioxidant metabolism pathways. And then we also are looking, at a gut microbiome test. We want to make sure that there's not extreme imbalance. We look at a tox test, that's a urine test. So we're looking for mycotoxins, which are from molds. We look at heavy metals, and we look at other environmental toxins. Like we mentioned, phthalates come from plasticizers. I just had a client, he was talking about they grew up in a household with a smoker, so they're going to have NACE on their tests. And so there's a lot of things that we just kind of we don't know because we don't know, and they're going to show up on these. And that, in conjunction with, I do look at food sensitivities through a serum test, um, and then we look at the hormones. So that's kind of going to paint a broad picture. We're looking at adding metabolomics in. I haven't adopted that in every situation yet. I feel like we'll get there. That's the next kind of step. There's not one particular thing that I hang my hat on. I think everybody gets exposed to a lot of toxins, and once your genetic capability is exceeded, you become, symptomatic.
So it sounds like then when we're dealing with breast implant illness, like kind of the treatment process you're really guiding people to is removing the breast implants, but then also clearing up all these other toxins that have accumulated around the body that are going to be unique from person to person. Do I have that correct?
Right. Our team has a group of functional practitioners at my both in my clinic and remote that help with detox, and we use Cellcore for detox. But we get our baseline testing done to create a plan, because obviously people are going to have different, issues depending on where they grew up and what they got exposed to, maybe where their family worked, or what industries were around where they grew up, or the states. I mean, it's a lot. It just
It is.
depends.
Yeah.
So
Well, what about other things like leakage of the breast implants? Or I'm also wondering if you see situations with breast implants where the lymphatics, because we have such a huge part of our lymphatic system in the breast tissue. So I'm also wondering like about leakage, how much of a problem that is, if that's something that people should be concerned about, as well as the lymphatic system and any congestion that could be created from the breast implants. Do you see that?
yeah, we see congestion in the lymphatic system pre-op and post-op, and
Mm-hmm.
and we used some devices from New Zealand called Flowpresso for lymphatic massage, and I have a really skilled lymphatic massage therapist. But when we're doing the whole body or the trunk, it's hard to get enough time with each individual patient, so we do the use the devices. In terms of leakage, that's a great question, because the The rupture rates will vary, but about 0.5% per year after 8 to 10 years is what we would quote. So I assume anybody with 10-year-old implants has a rupture because most of the studies are not sensitive and or specific enough to show you a posterior leak, so up against the chest wall. You would need a devoted breast MRI really to show that, or like Dr. Jen Simmons has QT imaging now. That would be super helpful. We hope to have that at some point. But I always consider that. And if someone has lost um, the ability to, on exam, have a structure, you're worried about that implant having lost its integrity and leaking. If someone became extremely symptomatic after an event, like a car accident or a fall, then you would be concerned about that, and they would
Mm-hmm.
have to get some kind of imaging to help um, further delineate that.
That makes sense. And then I'm also curious about like in the process of the removal, like where is that done within the process of everything else? So like for example, if you test somebody for mold and metals and other environmental toxins and they have leaky gut and thyroid abnormalities and these that they have the breast implants, like is there like a certain order where it's like you always got to start detoxing a little bit before you do the removal, or is there another kind of step-by-step process that you see to be common?
So the way we go about it, I create this pathway based on what the patient's, expectations are. And if they have a really obvious toxicity issue, I tell them it's better to get all of your testing done. Supplementation begins and lasts about a year. And I want everybody to have this level playing field. I want to see like what is their tox burden now and their ability to handle that and get them started. Because usually I'm booked several months out for surgery. So it gives them a chance to get started. And if they really are interested in having a fat transfer, we really need to know where they begin with that because toxins are, as we know, stored away in fat tissue. And so we want to have a better understanding about that because fat transfers work extremely well. We have a lot of experience in my practice. I've done several thousand fat transfers, and it's more about making sure the patient's optimized rather than is the equipment right or our strategy correct. We have all those things, all those elements in place, technically, all that sorted out. It's trying to get them in a optimized situation is, we're obviously, I see people who are out of balance all the time and trying to get them into a better balance so that recovery is more efficient. I think my patients and women in general tolerate a lot more because of what their position is. Like they're working, they're taking care of their families, basically the primary, caregivers for the everybody. And so they just kind of push through things. This is not one of those times where you're just gonna force your way through and recover. So I know that, and I have to put the brakes on a lot of people and tell them not no, but not no for a fat transfer sometimes. And nobody probably really wants to hear that, but if I don't feel like it's going to work or the tests show that it's going to be harder for you, we want you to work with the detox practitioners in our clinic and remotely if that's necessary and get yourself into a better position. And if we can't or you're not feeling well, then we do an explant with a lift and wait to help do the fat transfer at another time. Many times we do those under local in the office, which is another option. So there's not another anesthetic involved. It minimizes the recovery in that respect. So there's a lot of ways to get it done.
So my curiosity with that is, and that this might be an unknown, but we do know that we store toxins in our fat, right? So my curiosity then is some of what the concern is in people that are just like not maybe a good fit for the fat transfers. Or ever like a worry about, hey, we are going to mobilize too many toxins with the transfer of the fat because of how many toxins are stored in the fat cells, and that could lead to a real big like Herxheimer negative type of reaction. Is that ever part of the concern?
Yeah, and that's where the discussion shifts back to balance. So if we get somebody who's obviously out of balance, which the majority of my clients are, and trying to get them on the right diet and supplementation, air filtration, water quality, food quality situation, that will help them. And then looking at their detox situation and creating a plan for them and starting that has been our best answer to that question. That,
Yeah,
everybody's got toxicity, both you and I do. And I think you would say to me, like, Rob, you need to do XYZ. And, all of us have to be doing something in order to keep our tox burden under control.
absolutely. Yeah, no, none of us get away from exposure or even buildup. It just doesn't happen. Nobody, I've never seen a clean tox panel in my entire life. So maybe
Yeah.
somebody will surprise me, but we all get exposed.
Always.
So what do you feel for like people in situations like double mastectomies? Like, what do you recommend for people in those situations? Is there ever a situation where you would recommend implants, or have you just seen so much, problems with them that is just something that you feel that people should avoid in basically every situation?
No, I think, the way I think of all these discussions is when I was doing cancer reconstruction predominantly, if someone came in, the options were an aesthetic flat closure, a expander implant based reconstruction, or a single stage implant based reconstruction, or a autologous or using your own tissue reconstruction. And because I did microsurgery, predominantly people referred to me to do autologous reconstruction with a DIEP free flap. Now, from time to time, I couldn't do that, or the patient, didn't want that and they wanted implant-based reconstruction. Most of the time that was done with an expander, then converted to an implant. And, you know, it's not about like not doing the procedure, because cancer puts you in a predicament where these are the available levers, and each case you just have to help them make the most informed decision. That's basically it. Obviously, I know a lot more now than I did when I was doing reconstruction for over 20 years, but I always was very reticent to recommend a implant-based reconstruction who in somebody who already had an underlying problem with like IBS or like Sjogren, like any autoimmune thing. Always
Yeah.
put me off. I was like, I know if I did an autologous reconstruction, there's zero chance it's rejected. All I have to do is make sure that from a technical standpoint, I get the blood vessels hooked up so that it would perfuse properly. And we were above 95%, for my career. So that was, not a given, obviously, but it was very high success rate. And so then you would know that there's no chance that patient's having a reaction because it's their own tissue, provided
Yeah.
everything obviously went well. So I always leaned that way. And then I think because I did so many of those cases, I built up a system of people who had problems with implants got referred to me. So that started happening early in my career oh gosh, it's probably as early as 2007. So I just started taking care of and converting those reconstructions that had problems either from capsular contracture or radiation injuries or infections or just pain. Sometimes people would just have pain and they're just like, do something with this. And that ended up, it was like my gateway into taking care of those problems, but every implant's going to have a version of this: knee, hip, breast, dental, cardiac, spinal. I mean, there's not one thing you can name that I haven't helped somebody take care of.
Yeah. Yeah. And it sounds like what I'm hearing, and one of the things I wanted to point out for our listeners is that everybody, it's your own decision with what you do. But the biggest thing is there are other options to be informed about that. Hey, if you're interested in like looking at an implant, that there might be other things that can be done. So that sounds accurate, right?
Yeah, we have a whole series, and for patients, so the audience understands. When I would have a patient come for an augmentation, which was not common based on my inability to see patients because I was from a scheduling standpoint, it wasn't easy to see me. I would talk about fat transfers, which is taking your own tissue. So a fat transfer can be done if someone just wants like a cup size change, or if they wanted purely their own tissue, it would be a series over time, you
Yeah.
know, one a year for a couple years or 3 years or whatever. Or if they wanted to go from uh, a B to a D, that was always going to be an implant based situation. That's cosmetic, of course. And
Hmm.
then if somebody was getting a reconstruction, they were always going to have a much different scenario because of the amount of tissue, being exchanged for breast implant volume. So those were all things, you know, although I did predominantly cancer reconstruction, I had the same conversations almost with the cosmetic patients in terms of options and recovery and how I ran recovery, I should say. So I always saw people like a week and a month and 3 months and 6 months and 9 months and 12 months because that's how I saw my cancer patients more frequently. So I ended up seeing everybody kind of on the same schedule, and I just kept that throughout my career.
Sure. Makes sense. Well, this has been amazing. This is so much information. And I think the biggest thing is helping people be aware of like the toxicity that these implants can cause, just for a point of awareness. Everybody, we're going to have information as far as working with Dr. Rob's practice out of Austin, Texas. I know people fly in from all over to see him. And so there's ways of working with him in that way. We'll have all that information in the show notes. But before we close up, is there any like final points, final like message or takeaway or anything you want to leave us with?
So you mentioned Herxenheimer earlier, and we didn't really talk about this, but you made me think about just saunas. So a lot of folks use infrared saunas. I've had patients have more reactions like detoxing too quickly. And then I've had patients use barrel saunas. Then barrel saunas get up to, like above 200 degrees Fahrenheit. And I've had people cause leaching out of their implants, and we've seen this on their toxicity tests. There's so many heavy metals. So just be cognizant of that. I don't know how to guide people on the use of IR or barrel saunas. So I have them just pause that until we do their explant and give it about 90 days till they resume any kind of sauna therapy afterwards.
Yeah, thank you for adding that. I've seen saunas do very similar things. It's a very easy way for people to just do too much too fast. So thank you so much for adding that. Thank you for your time today. And everybody remember that this year, what we're doing is for the year of 2024. Download the podcast, share them with your friends, spread the word. And whichever guest has the most downloads and shares, we're going to invite them back for a deep dive. And I know I certainly would love to have Dr. Rob back. So please do download, please do share this with your friends, and please do check out his website if this would serve you at all. So it's been great talking to you, Dr. Rob. Thank you so much for being here. And to everybody else, we'll see you real soon.